Yeah.
Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again I'm super excited to be your host and have the chance to share this platform with all of you. Absolutely, I'm so grateful to have great friends and educators from around the globe joining me and joining you all and sharing their knowledge and experience. And today I have a very super talented friend joining me on Hot Seat. Dr. Dmitriy Ivanov is here with me from United States. Hello, Dmitry, and welcome, my friend, to Hot Seat. So
Thank you,
happy to
Omid.
have
Thanks
you.
for having me. Really appreciate it.
Thank you
Thank you.
so much. You know, the topic that Dmitry is going to talk about for us is absolutely one of the most demanding topics in field of periodontology and also implant dentistry, and that's about proper soft tissue management around teeth and around implant. And definitely our focus today going to be on aesthetic zone. And me myself, I'm pretty sure you all will be super excited about the technique that he will try to introduce to us, or at least review it for us. And he called it 3mm hole technique in root coverage procedure. So I'm super excited for that too. And before we start, I would like to have Dr. Dmitry Ivanov's CV for all of you. And for sure, at the end, we will have a quick discussion on the topic, and I'm pretty sure it will be exciting. Dr. Ivanov is a board-certified specialist in periodontics with a focus on the treatment of periodontal disease, hard and soft tissue augmentation, and dental implantology. He received his bachelor's degree in biological sciences from UC Santa Barbara, graduating with highest honors, and was awarded a DDS degree from the UCLA School of Dentistry and continued his postdoctoral education in advanced periodontics and implant dentistry residency at Veterans Hospital of West Los Angeles, UCLA Medical Center. Personal and professional interest of Dr. Ivanov is he's a former instructor of periodontics at UCLA School of Dentistry in Westwood and UCLA Venice Dental Clinic. And I have to say, there is a partner of Dr. Ivanov. They call their group Perio Amigos, Dr. Fadi Hassan, which will be also one of my guests in season 3 of Hot Seat. So you will see also his presentation soon. So Dimitri, I'm so excited that you accepted and joining me and all of our friends in Hot Seat. And we are ready for your beautiful presentation, my friend.
Absolutely. Thank you so much for having me again. So today hopefully will be educational, but it's probably going to be a little bit fast-paced. And, I would like you to ask me questions, as we go through this. So kind of encourage the discussion, if you will, Omid, okay? So, I wanted to kind of start the presentation with, these very common presentations that we have, that this is kind of a bread and butter in some of our practices that patients come through, with either broken teeth, teeth that are missing already, that's been extracted, or teeth that, present with these periodontal problems, or, teeth that are relatively hopeless. And they bring a ton of different challenges along the way, in the management from the standpoint of soft tissue as well as standpoint of bone. So as you can see, the three cases are all very different, and the management will be all very different as well. So let's just move along here. 1 second, not clicking through. There you go. So as far as looking at the management and the implants in the aesthetic zone, I just wanted to kind of hit high points that the temporization is ultimately one of the key points in developing the soft tissue profile, and which is what I wanted to kind of touch upon in the next few slides. The way to achieve the natural aesthetic emergence profile is by two ways. You can either preserve the aesthetic profile by a custom tempore or a custom healing abutment, which is what you see here. In a lot of cases, we can't preserve the emergence profile, so we have to develop it with a custom tempore as we go through the treatment, our treatment execution. So immediate tempore generally is done to support the tissue, support the contours of the existing tissues, existing papillas, which could be done chair side with the support of the lab, or it could be done created chair side just purely with customizing the emergence profile by hand, which is what was done in this particular case. The tooth was extracted, The implant was placed immediately, and the immediate temporary was picked up the same day. This was actually made by the lab. The shell that I'm utilizing here that you see is the lab makes me a shell that's pre-made with the proper shade, and the super gingival contours are already pre-shaped. But what I custom make is the subgingival emergence profile, and that's the part, the critical subcritical zones of the emergence is what's going to support the papilla as well as support the facial gingival margin to preserve and hopefully support the tissues so they do not collapse, they do not recede during the healing. A post placement, in a lot of cases we cannot achieve primary stability in a lot of the immediate implants, even though we may use a more aggressive implants or a longer implants, we still sometimes not able to fabricate a chair-side provisional immediately. So in some of the cases, we need to place pressure on the tissue to be able to fill in the papillas, to recreate papillas. Like this case, for example, I placed an implant and I was hoping to do an immediate provisional for her, but the torque value was way below 25. So instead, I put a healing abutment as seen right here. It's a very narrow, low-profile healing abutment. And 3 months later, I came back and I created a chair-side provisional in a similar manner as before. Lab made me a shell that I relined. It created.
Good.
Okay.
You can go.
Ready?
Yeah, ready.
All right. Great. And in some cases, as in this case, we're not able to place the immediate temporary during the placement. Like this case, she came in with the hopes to get the immediate temporary the same day, basically, as the extraction, but we were not able to do that due to low stability of the implant. So we placed a low profile healing abutment, and I fabricated a chair side immediate provisional, not immediate provisional, but the chair side provisional that was done to fabricate the custom emergence profile for to be able to shape tissues. You could see fast forward just about 2 months, and the papillas have filled in, and we see a beautiful outcome of the temporary on the lower right. Let me do a laser pointer here. This is a temporary, and beautiful gingival zenith, beautiful papilla position that allows us to restore kind of a natural custom emergence profile for the tissue. So another way to, not all the cases could obviously be temporized. So this particular case was specifically not able to temporize because of the absence of posterior support. So we could not per se, even with the presence of some of the posterior teeth like premolars, she was missing most of the molars. So we decided to avoid any possible occlusal overload on these implants. So instead, we can fabricate a custom custom healing abutments that basically replicating the emergence profile of the temporary restoration without the actual supragingival, structure or the tooth structure. So the emergence profile and the way we shape the subgingival profile is very similar to conventional immediate temporary. So implants are placed in a similar way, even though they had pretty good stability. These all torqued out above 40 newtons. By the way, generally my rule of thumb is to be above 30 newtons on my implants if I do want to place a temporary or custom temporary to temporize the case. But even though both of the implants torqued out at a high torque, the absence of posterior support kind of made me place a custom healing abutments, which is perfectly fine. It does serve the same purposes, just not as aesthetic, obviously. And patient was fabricated in an Essex appliance to wear during the healing period. She was she's maybe 75-year-old lady who did not a period of time, and then she's believed for these implants that we placed. So that's another way to kind of salvage if you're not capable of fabricating a temporary, or you don't have maybe either skill or maybe a tooth that was pre-made for you. You could go and fabricate a custom healing button. Those are excellent choices to do that. And just wanted to go over a kind of a comprehensive case where these techniques could be utilized from the standpoint of not just obviously the temporary, but I wanted to kind of dive in a little bit about soft tissue augmentation and a bone augmentation in a case like this. So these type of cases, you know, if you're looking at it as a periodontist, you might think, hey, I mean, this looks like a tough case to do a root coverage procedure, right? I mean, you would not jump in and say, this is going to be a predictable root coverage. And obviously the X-ray shows us that it's possible. And so this was a complication from an endodontic procedure. They did a apicoectomy that went down south. The patient lost a lot of attachment, developed severe recession. So these kind of cases, obviously, it's not a single stage case. I just generally stage these type of cases, and I extracted the tooth. I let the tooth heal, or the area heal for at least 2 months. That allows for soft tissue maturation and sort of gives me as much soft tissue coverage for my future graft. And we approached this case as a GBR case. This was treated as a sausage technique used here, autogenous mixed together with an allograft rather than a xenograft. I'm not sure how you guys do in Iran, but we have a lot of available good quality allograft in the United States compared to like Europe. It's harder to come by. So I utilized, instead of a xenograft, I used an allograft for the similar technique as Ivano teaches, the sausage technique, or a mini sausage here. And we let this heal for about 6 months. At 6 months, I did you know, the bone was already there and we were ready to place the implant. We obviously were still lacking in soft tissue volume. As you can see, there's indentation on that up left picture. So these type of cases definitely require a little bit more volume from the soft tissue management. So this could have been done as a VIP CTG, but I decided to just as a free CTG, I took connective tissue graft from the palate. We did a conservative flap here with a papilla sparing incision, and I fabricated, we placed an implant. We did a connective right with an ideal emergence profile. Generally, you want to be a little bit short on the zenith of your temporary restoration, just a little short, about 0.5 millimeter short to the final in terms of the critical, subcritical. I'm talking about this area right here, along the zenith of the temporary restoration. So you put very little pressure in that area. And we let this heal. So this is a 3-week follow-up. You know, we were able to gain beautiful thickness, beautiful attached tissue, you know, keratinized tissue. This is only 3 weeks. So generally, we would let this heal for about 4 months from the time of the implant placement, 3 to 4 months. And then we came back to it 4 months later to do a follow-up. As you could see, that we were able to develop beautiful emergence profile. We were able to you know, to almost replicate the original papilla height, at least in approximately the midline papilla. And the gingival zeniths have tremendously improved from the receded tooth area. And I always, for these cases, fabricate a custom impression post or custom impression coping. This is the picture on the right. As you can see, that allows me to replicate the emergence profile for the lab, and the labs can sort of copy the emergence profile of my existing restoration. So this is kind of how we walk through. This took about a year to really complete between the GBR and an implant placement and a healing, but certainly definitely an improved, more healthier, more long-term solution for this patient. In this case, kind of highlights the very few, you know, techniques that we utilize in daily basis, you know, from the bone augmentation to soft tissue management and temporization for these aesthetic cases. Another case that I kind of want to bring up, and we're showing a posterior areas, very common, again, kind of a bread and butter cases. Some of the posterior areas that are edentulous for many years, we are missing both the tissue and bone in a lot of these cases that require both of those staged augmentations in a lot of times. So let's just review at least this case that was managed both from the bone standpoint and a soft tissue standpoint in a staged approach. You know, similarly, we treated this. In this case, the bone was thin, so we were able to place the implants and augment at the same time. As you can see, we were mostly augmenting the premolar site and the most anterior site. We did a similar approach as a sausage technique. We fast forward 4 months. I'm showing you 4 months as we still not ready to open this case. These cases we leave for about 6 months, but this case came back, and I decided to do an augmentation at this point. And as you can see, there's a lack of ample amount of keratinized tissue, so we had decided to add some free gingival graft. This free gingival graft could be done at the time of a stage 2, if you're, you know, if you're able to manage that. Generally, if I want to remove tax and things like that, I generally avoid doing a free gingival graft and a stage 2. So I tend to stage these cases. So 4 months is pretty good time to do a free gingival graft at this in this situation. So free gingival graft was done. This is basically an epithelialized, very basic periodontist. Any periodontist should be able to manage the free gingival grafting like this to augment the keratinized tissue. This will give us plenty of time. So let's fast forward 6 months from the time when we did a placement and a GBR. We look at our bone. We're pretty happy with our augmentation procedure. And then we fast forward to about stage 2. So I'm showing you I'm skipping a few steps, but I fast forward, you know, to 6. I think this is 6 weeks post. 4 weeks post stage 2, when we already exposed. As you can see, we gained not just volume of bone, but tremendous amount of soft tissue thickness around these implants. It gives us a very, very long-term stability, and hopefully these implants kind of giving everything we can to these implants to survive for hopefully many years. So just highlighting another case. I'm not going to go through all the challenges here, but it's treated very similarly. Instead, in this case, I decided not to augment soft tissue prior to stage 2. I exposed the case first, and then I did a soft tissue augmentation for this case after. So this is kind of how we ended up. As I don't know if you can see pre-op and a post-op, massive gain in the volume of bone. This was treated simultaneously with the bone and the implant placement at the same time, and then we augmented soft tissue kind of for long-term success. So again, basic things for most periodontists. Sometimes you can stage them, sometimes you can do them at the same time, depending on the skill level, because it's not everybody have ability to do that all at once, because maybe it's not as predictable. So some stages, and I love staging myself. I'm a big proponent of staging things, even though it takes longer. But if it gets better over a longer period of time, it's less stressful, if you will. So, you know, we're moving along a little bit faster. Do you have any questions, Omid, for now? You're good. Okay.
Everything clear, crystal clear.
Okay, very good. Just want to make sure we're pacing just fine. I'm going to talk a little bit about some soft tissue augmentation now in terms of the teeth and how we manage certain things kind of in the challenging cases, and how we manage root coverage procedures, and maybe some implant management as well. So 3mm hole technique is nothing new. It's a technique that was described by Dr. Moghaddas, one of my older mentors when I was in residency. Dr. Moghaddas is an amazing periodontist who developed the VISTA technique, who I've been using probably for the last 7 years, and it's quite an excellent technique for augmentation as well as root coverage procedures. So, let's review this a little bit challenging case. And, if you look at, if you ask 100 periodontists how to treat this case, everybody would probably have a different approach. Some of them might say the free gingival graft would probably be a better option here. Some would say connective tissue graft. Some would like to flap it, and some would like to tunnel it. Generally, in cases like this, I tend to tunnel most of my cases with a good vestibular depth, but VISTA is or 3mm hole technique is a technique it's a full thickness tunnel technique that allows us to to create a pouch or a tunnel instead of conventional tunnel like a Pat Allen technique that when we tunnel through the sulcus. In this particular technique, we tunnel through the vestibule, and it's a full thickness tunnel, meaning the periosteum is completely lifted off from bone. So it's a subperiosteal technique. This technique allows us for a much easier, faster introduction of the graft material instead of going with this. If you're looking at this very thick graft, connective tissue graft, putting this through the sulcus would be very challenging. So we tend to introduce this graft through the VISTA technique. As you can see, this is about 2 to 3 millimeters in incision. That's the only incision that patient receives in the vestibule. Obviously, you have to be mindful of the vital structures like the mental foramen and things of that nature. But you do virtually everything: the tunneling and the introduction of the graft through the VISTA incision, through this vestibular incision, and the suturing is virtually identical to a Pat Allen technique, like a tunneling technique, where the graft and the flap is coronally advanced together with these interrupted sling sutures. So graft is introduced through the VISTA incision, graft is secured to the flap, and through the graft with the sling sutures, and everything is coronally positioned. Let's just fast forward 3 months, and this case was specifically challenging is when you have an exposed crown margin. Crown margins, if the crown margin is obviously below the CEJ initially, you could certainly consider getting 100% root coverage. But if the crown margin is above the CEJ, sometimes you may not be able to cover the crown margin. And in these cases, I tend to find better results if I take thicker connective tissue grafts, thicker than usually 1 millimeter or thicker than 1.5 even in some cases, because tissue is supported a lot better, a lot easier with the thicker grafts than thinner grafts. So in this case, the quality of the graft was very good. And by the way, this is taking as epithelial, subepithelial, and not a deepithelialized pregingival graft, even though it looks a good kind of very whitish. It looks almost like a deepithelialized pregingival graft, but this is a subepithelial harvest. Palate was just very good. And then 3-month follow-up, obviously we've gained tremendous amount of root coverage and improved the keratinized tissue around both of these teeth. But look at the coverage of the crown margin, and this is very consistent and also tends to be very long-term. If you are able to get a very nice thick attached tissue here, as you can see, we're able to gain not just root coverage, but to gain a keratinized tissue. But we also have to look at the width of zone of the actual attached tissue beyond the keratinized tissue, because all of this attached mucosa, as we call a functional mucosa, is also part of this whole complex that allows the stability of the tissue around these teeth for many, many years. It's thicker, it's very firmly bowed down to bone. So that's what really gives us the whole picture, not just the gingival margin of being thicker and keratinized, but also the entire portion of that connective tissue that regenerated attachment. So that's a tough case, but managed really well with an autogenous tissue. There's another common case. We see a perifunctional patients that have a lot of fraction lesions. This was my buddy from college, actually. We treated 3 quadrants of this with the connective tissue grafting prior to his ortho. So fractions, again, if we missing a tooth, we could be, fraction could be missing a tooth, and meaning enamel. We could be also missing a root surface, and a lot of times we're missing both root and enamel and dentin. So in these type of cases, we're able to manage the soft tissue. Generally, I like to manage soft tissue first before considering doing restorative treatment on these cases, like class 5 composites. So I prefer to dial in the soft tissue root coverage first to as much as I can. And if we don't have to put composite at all by smoothing out the rough surfaces of the teeth or the fraction lesion, then we just leave it alone. So this case was managed in cases where I tend to get a larger graft, longer than 3 teeth, 3 to 4 teeth. Like in this case, I tend to go with the deepithelialized pregingival graft because I can take a longer strip, even though it may not be as thick as a subepithelial harvest, which I like. but it can be long enough to cover these 4 teeth. And the treatment was very much the same. We used the 3 mm hold technique, incision. It's again full thickness. You go straight to bone, and it's subperiosteal to elevate all of the tissue from the vestibular incision. You were able to tunnel under the papillas as well, under each of the papillas. So everything is still attached as a tunnel, but it is all full thickness lifted from the mesial to the distal aspect. And a one key point here is if you're tunneling and covering these 4 roots, you have to be able to extend your tunnel to at least 1 papilla over. So not just this papilla, but 1 papilla mesial. And you want to go at least 1 papilla distal. So you go to the distal of the second molar here. That allows you to get the maximum passive elevation of the tissue. So the graft was introduced through through that VISTA incision. And as you can see, the result speaks for itself. That autogenous tissues is still one of the best tissues to work with. We're able to get an excellent root coverage. Yes, there is still a little bit of an enamel missing, but it's not my concern at all. This does not need to be restored. He has no sensitivity. That's another key. If you have obviously sensitivity, a root sensitivity, you may have to put a restorative material, but in majority of cases, you just need to smooth this out. Great root coverage, great gain in keratinized tissue, but look at all occlusal view as the width of the actual attached tissue that's gained. So you actually deepen the vestibule with the placement of that autogenous tissue. You reposition that, even though it's mucosal tissue in this part, but it's very firmly attached to mucosa. Again, we call it functional mucosa. It's a great tissue to surround the teeth and the implants. Obviously, keratinized tissue is gold, but if you get more thickness and the attached tissue, that is also a huge plus, which is what you can do with autogenous tissue, with a connective tissue. Another, fun case, challenging case, these lower anterior cases tend to be very challenging because of the presence of shallow vestibule, just thinner bone, thinner tissue, and just the papilla areas tend to be harder to reposition. This case I treated as a VISTA technique plus combination with the laterally closed tunnel technique. A lateral closed tunnel is a relatively newer technique. I think it's about 2 years old. That was published in J. Perio, I believe. But it's a very simple technique of just simply closing the released tunnel laterally. And as if we look forward, it was treated similarly in terms of the full thickness tunnel. I made 2 incisions. I made the second incision right in the area of the frenum to give you access to be able to release the frenum a little bit from the inside if you want to, if you need to. The graft was taken. This was a kind of a long deepithelialized pregingival graft that was placed inside. But as you can see, this particular area with a deep, narrow recession on the lower anterior, we closed it laterally, meaning we brought the 2 margins of the tissue together, of the receded area together, after we deepithelialized gingival margins. So these areas need to be made deepithelialized, meaning we need to make them raw and expose connective tissue to be able to reposition connective tissue to connective tissue. By closing that together, you don't have to actually bring that most apical portion of recession coronally, and that way you don't obliterate the vestibule as much. You maintain the vestibular depth well, and you have an easier time. The laterally closed tunnel generally works for very relatively deep and narrow recessions, so the distance between the 2 is not too far to close. So great technique. I really enjoy doing it for these lower anterior cases. Fast forward at 4 weeks. This is 4 weeks. You can see obviously beautiful root coverage, but great gain in thickness. As you can see, this is sort of the old outline of your recession area, and whatever is in the middle, that's the graft that we've placed. That's the graft that we are placed underneath, just like Sir looking from the inside. The graft is here. It's also nice to leave some of it exposed if the graft is thick. And that will give us a beautiful closure and a beautiful regeneration of keratinized tissue in these type of situations. So beautifully managed. It's relatively, from the standpoint of patient, also this technique, because it's full thickness. I tend to find it less less of a swelling in most patients compared to like a split thickness technique where you're sort of going in and splitting all the periosteum within tissue. So you don't cut into a lot of the tissue. That way I tend to find it easier recovery for the patients. You know, these type of cases can also be applied to more broader areas. Obviously, you could see this is a very wide zone, and these type of cases could be a lot of times treated with, you know, we didn't talk a lot about allografts today, but these type of cases could be certainly considered for an allograft because it's a maxilla. It's more predictable to get root coverage in maxilla. You generally have more keratinized tissue. The tissue is more thicker. Vestibular depth is deeper in the maxilla, and absolutely this kind of case could have been treated with an allograft of some sort, whatever your preference is. This particular patient did not want allograft due to religious reasons, so we decided to take tissue from a bilateral side of the palate, so both sides of the palate, and because there are 4 teeth each, we took it as a de-epithelialized pregingival graft. But the technique itself was very similar. We utilized the VISTA technique to create this vestibular incision here, or 3mm hole technique. Everything was tunneled distally on both sides, and obviously coronally. We left a little bit of connective tissue exposed in the central area to because the graft was relatively thick. Sometimes you tend to leave it exposed. Not that we needed keratinized tissue in this case, but we, you know, why not if we can get some more? And then we fast forward to about 2 months post-op, as we could see the even more gain in connective tissue thickness. Again, not that we needed any more thickness here, but more is always better, in my opinion, for these type of cases. She has a relatively high smile line. She actually improved dramatically aesthetic, you know, from the aesthetic standpoint, as far as where she started and then where we ended. And these type of cases tend to do really, really well long term. We obviously have to control parafunctional habits. We have to control the brushing, inadequate brushing, or whatever the etiology was. It's a very important to factor it into the treatment plan, whether you're going to provide a night guard for the patient, whether the patient's going to be using an electric brush in a different way, and you know, all those things. So that's a good discussion with the patient. You know, this is a cool hashtag that if you guys on Instagram, I'm sure you'll be able to see this hashtag. Is you know, it's a great hashtag to follow. What is it, Omid?
Make FGG great again.
Yeah, make FGG great again, as if it's never been great before. But you know, some of these cases, we look at it and we ask ourselves, what is the main goal of this treatment? You know, and what is the chief complaint? Obviously, patient came in for she's just worried that she's been receded. She's in her probably 70s, maybe late 60s, and she's been losing the gum for quite a few years. And when we're looking at these, we ask ourselves, is the root coverage possible in these cases? Yeah, we could certainly get some root coverage on some of the posterior teeth, but when we're looking at the anterior teeth where with the severe bone loss, we tell ourselves that maybe this is a Miller 3-4 type of defect. We may not get a lot of root coverage. So in the cases like this, generally, especially lower mandible tends to have thinner bone, thinner tissue, thinner keratinized tissue, shallower vestibule. And in these kind of cases, I tend to look more for augmentation rather than root coverage. And the best augmentation for a lower mandible or anterior mandible, nothing works better here than a free gingival graft. Just a connective tissue graft would certainly work, and we would get a partial root coverage on some of these teeth. We would get more root coverage in the posterior teeth, but anterior, lower anterior, you may get partially. So my goal here was to augment as much keratinized tissue as possible with a nice zone of a free gingival graft, utilizing, you know, just a free gingival graft. And let's see how we treated this. So long cases like this obviously we require to go to bilateral sides of the palate to grab that tissue, and this is what we did. a little bit convoluted with the suturing, but I won't elaborate too much. But generally, when we want to recreate the vestibule, I like to utilize these T sutures or base ties to basically apically position the tissue and secure that tissue apically to create a deeper vestibule. You know, the basis of free gingival graft is to create something that doesn't move during healing. You know, if you can glue the thing into place with sutures or whatever you use, it's going to work. That's how predictable free gingival graft is. It's very hard to fail a free gingival graft unless patients, I don't know, start picking at it or brushing it or something like that. It's very, very predictable. So if we look forward 4 weeks, you know, we certainly got a huge amount of keratinized tissue. We deepen the vestibule. This entire area is like a leather belt, so thick and robust that it's not going anywhere. We also expected, and we did get some root coverage on these cases, and majority of these will continue to get root coverage by creeping attachment in the next 6 months or even longer with a good oral hygiene. So did we ask ourselves, say, do we achieve the most possible root coverage? Maybe not. We could certainly consider a subsequent step to do a root coverage procedure if the patient desires. But again, this wasn't a desire of the patient. She's able to manage her oral hygiene really well around the, as you can see, tissue is very healthy. And with the presence of this robust tissue, I think she's going to maintain these teeth for many, many years to come. So that great outcome overall. You know, I would not worry about any root coverage for this case at all, any further root coverage. But what about cases like this? There's some aesthetic cases that we want to, let's say, restorative dentist wants to even out the gingival zenith across the teeth. There's an abrasion lesion. There's kind of uneven gingival zenith exposed crown margins. So these type of cases, we could also, again, utilize either a autogenous tissue, or in her case, I think it would have worked well with an allograft as well. With a thicker allograft, I would prefer maybe a Straumann allograft or Salvin allograft versus an alloderm per se, because it comes a little bit thicker, just in my hands. But in this case, we utilized an autogenous tissue. Similarly, we took a free gingival graft that was de-epithelialized. Thicker the graft, and again, when you're covering not just roots, but when you're covering exposed crown margins, I find it helpful to take thicker grafts because they support the gingival margin better. Thicker grafts tend to, we're just going to fast forward this. This is, I think, 2 weeks, and this is a 2-month follow-up. We're able to gain beautiful coverage of the exposed crown. She's going to be actually redoing these crowns with 2 veneers in the front. And we were able to cover the exposed for abrasion lesion. That's another good question I always being asked is do you need to restore the abrasion before? I say, let me just cover with tissue first and see how much coverage I can get. And then we can talk about the restorative aspect and stuff like that. Even though literature says that the CEJ should be restored prior to the root coverage procedures, it always worries me, what if I don't get enough coverage up to your composite restoration, you know, and then we might be in a little bit of trouble. So, you know, that's all I wanted to share in terms of those few techniques. I know I went a little bit fast, Omid. Do you have any questions for me?
Yeah, sure. First of all, thank you so much for sharing those beautiful cases. Step by step, every detail was there. But I have some comments and questions, and I would be happy to hear your thought on that. First of all, regarding the case that you showed with the fraction in the left part of the mandible, as I remember. And you said that you prefer to do the graft first and then come back to see if you need to do any restoration. Usually I see in cases that have abfractions, in long term, the tissue tends to go more apically. I want to know, do you have any consideration or any specific protocol to make those abfracted surfaces rougher to enhance the tissue attachment to them? Or do you have any protocol, EDTA or anything else, or you just put the graft on top of it?
So, you know, that's been studied for in a lot of articles. If we look at this study by Mariotti, it's a systematic review. Maktai also posted on that topic, and they compared use of EDTA, citric acid, tetracycline, for both regenerative purposes like GTR procedures as well as root coverage procedures. And even Homozadeh, his paper talks about EDTA use for 3 minutes. Generally, it's been proven ineffective for the standpoint what we used to think, you know, from the standpoint of exposure of sharpest fibers, making the tooth rougher, you know, from the standpoint of like better root surface and stuff like that. Generally, if you can, if you look at these systematic reviews that said that it doesn't matter, that it absolutely has no benefit on using any of the modalities, I think a very clean, well root-planed root surface with the scalars, and sometimes what I use is recontour the root to bring the root more into the alveolar housing. To if the root is very pronounced, I tend to find this work much better for long-term stability. Also, thicker grafts tend to be, if the roots are very convex and pronounced, the thicker graft tends to hang out better in these situations. I find it supports the gingival margin better long-term.
But Dmitry, my question was specifically on the abfracted surface, which are very you know, shiny and very, I don't know, glassy. So
yeah, absolutely, you got to scale the heck out of it to make it. I do make it rough, but with a scaler. If it's really shiny, I always take a scaler and I scale it to really make it. Yeah, absolutely, 100%. I also take a burr to it, like a I take a football bar to it, like right here. It's so shiny, it's like polished, you know?
Yeah.
Absolutely. You take a scaler and you scale it until you remove all that shine. You got to make an exposed dentin for sure. You have to root plane it.
Yeah. And regarding the case that you showed, it was in the anterior zone. It was like, I think from premolar to premolar that you did a root coverage. I noticed that you put your sutures, I think it was the sling sutures, but the interesting point in your technique was that you didn't pass the sutures from the base of the papillas. It was more to the line angle to line
angle to, yeah. So this is the older version of the sling, like a Pat Allen teaches. It's an interrupted sling. It comes from the line angle to the line angle. It doesn't go in the papilla areas at all. So you do want to stay at the line angles.
So which one you found better and more stable comparing these two techniques?
I find this, it depends. It really depends on how much interproximal tissue. I generally use, the other technique that I use is a composite button. You know, when you bond the composite and you sort of sling through the facial, I find this to be more efficient, this technique, to pass this through. I like to stay at the line angles because I tend to pull the tissue more coronally into the tooth better. So I find this technique to be easier for me versus like a composite bonding and all that stuff.
And any specific reason that you didn't put your incision in this technique in the pherenum area and you put it more to the lateral or not?
You know, very good question. I think if I was to go back, I would probably went straight through the freedom to give me a little bit of frenectomy to kind of utilize that option. I tend to do little frenectomy when I'm managing this from the inside. So I take a 12 blade and actually release the muscle from the inside, or take an Orban knife and do a little frenectomy from like an internal frenectomy, if you will. But I agree with you. I think this would have benefited right straight in the middle of the frenum. You could actually take that out, you know, take that portion of the frenum and make your, you know, VISTA incision there. I think it's a great idea.
I know your time is limited, but my final question, as we talked about FGG and make it great again, I want to know your experience on fixing the free gingival graft with tags instead of sutures.
You know, the only person that I've seen this done is Snezhana Pol. You know Snezhana, right?
Yeah.
Of course, yeah. So I've seen her do that, and I've been always so impressed. I had that thought in residency when I was like a first-year resident. I asked my attending, and he told me this is garbage. This is terrible. And then I see it like 5 years later. It works. No, it works. I think I would like to try it. It's just I haven't yet, but I like the technique. I like the approach.
You know,
It's
because
very cool.
I saw your beautiful cases. So especially in the case in the lower mandible that you showed, it was very broad. If you go with the tags and at least have little sutures, your surgery is going to be so much faster. You know?
Faster, no, absolutely, dude. I could put a couple of tacks in a matter of seconds instead of spending an hour suturing. That's a lot of suture. Yeah.
Dmitry, I have to tell you that I truly enjoyed talking with you, and thank you so much for sharing. And for all of our audience, Dmitry, please check his Instagram page for more beautiful cases by him, and also his partner, Fadi Hassan, which will be my guest in future sessions of Hot Seat. They share beautiful cases on their Instagram page, so you can see it now on the screen. And thank you again for joining me, and I hope to see you very soon. Stay safe, and hats off, my friend.
Thank you. Thank you so much. I appreciate it. Have a great evening. Bye-bye.
Thank you. Take care.
Thank you.